Hi, in this video, I'm going to be talking about your pathology report. What is it? What does it contain? And how to understand it. We have a lot of other videos that we will refer to during this video. Your pathology report is the report generated by the pathologist, which is a very specialized, important doctor in your care that you will most likely never meet. The pathologist is the doctor that looks at the breast tumor at several points during your treatment, especially during your diagnosis. So when you're first diagnosed with breast cancer, you usually have a biopsy. That will generate a biopsy report, and that is generated by a pathologist. The pathologist will say whether this is invasive cancer or non-invasive cancer, and they will usually give a preliminary grade. Check out our other video about grade, but grade refers to how closely the breast tumor looks like, how closely it matches normal breast tissue. And again, we go into that in much more detail, but usually that's what we get from the biopsy. Is this invasive or not? Sometimes the type, like infiltrating ductal, or they might also call it invasive ductal. They might say it's lobular or mucinous. You can read about other types of breast cancer histology, what it looks like under the microscope in our other videos. And it will also give a preliminary grade. We actually need the whole tumor to be able to tell you the final grade. So just as an aside, your grade may go from grade 2 to grade 3, or grade 3 to grade 2, 1 to 2, or 2 to 1. When you look at the final pathology report, when the specimen, the breast tumor, is completely looked at. So a biopsy may also give you the estrogen receptor status, progesterone receptor status, and the HER2 status. Those are things that can take a couple extra days because special stains have to be used. During all of this time, the final surgery will be planned for you. So whether you're having breast conserving surgery or a mastectomy, whether the lymph nodes are going to be removed, and whether that will be an axillary lymph node dissection or sentinel lymph node biopsy or assessment, I often call it, that decision will be made. After you have your main surgery, your primary surgery, that tumor is sent off to the pathologist and will basically be added as another pathology report. There are a couple parts of the pathology report that I want to bring your attention to. The first is the gross specimen, which doesn't mean the specimen was gross. What it means is just sort of the big specimen that they're looking at, and it's not under the microscope. So it's gross is the opposite of micro. So they'll describe how much the specimen weighed, and they'll usually do that in grams. They'll describe what the tissue looked like. They'll say whether the tumor is close to the edge of the whole specimen itself. They might say that there's yellow adipose tissue, that's fat tissue that the tumor is embedded in. You'll also see the gross specimen will refer to inking of the margins. When the tumor is removed, there's ink applied to all of 6 sides. Picture a beach ball, if you will, and there's ink applied to the top or superior margin. There's ink applied to the inferior, which means the lower margin. There's ink applied to the medial surface. That's the side closest to your median, your middle. The lateral is the side closest to the outside of your body. We don't call them right or left because it depends on which breast the tumor came from. So medial just means close to the middle. Lateral means the outside. The anterior margin gets inked with a different color, and that's the one to the front. And finally, the posterior margin, that's the back margin closest to the chest wall. So if you see that the inked margin is in blue, and they will tell you what the colors are. Not that important for you, but I just like you to know what you'll be seeing. So you'll see that the margins are inked. Then What happens after that is the tumor is embedded in paraffin, and then it's sliced with something called a microtome that slices the tumor into tiny little slivers. If you can imagine a vegetable grater, but imagine one that's even finer. So it's slicing the tumor into sometimes hundreds of pieces. Usually the pathologist won't look at all 100. They'll sample the tumor. Well, where they will look are all the margins, because they want to see how close are the margins to the edge of the normal tissue. We like to have a little space between the tumor and the skin. We don't want to be shaving the tumor off the skin or the chest wall. We like to see that the margin wasn't cut across. So if the tumor's transected, that means that the scalpel went through the tumor. And again, we like to see some normal tissue. You may also see a report on the extra specimen. Some surgeons will take the tumor out and then they'll also shave more normal tissue on all 6 sides. So it's like taking a book on each of the sides and the front and the back of the beach ball. And that's to make sure that the margins are negative. So even if the margin on the specimen is close, take a look at that extra margin to see if that complete margin is negative. I know we're talking about 3-dimensional structures here, but these are things you might be curious about. The final microscopic description of the tumor will say what type of tumor it is, what the measurements are, and that'll be height, width, and depth. As we've talked about in some other videos, check out the staging video, we use the greatest dimension. But the pathologist report will usually give the tumor size in all 3 dimensions. You will also get in the microscopic report the grade, the type of cancer, any other features like whether lymphovascular invasion is present or absent. That might also be called angiolymphatic invasion. They're exactly the same thing. You will also see at some point, it can take a couple days, just like with the biopsy, you will also see estrogen receptors, progesterone receptors, and the HER2 status, as well as the grade. So it's a lot of information. A synoptic report is a report that has every single one of those things I just covered in it. Again, the extra studies like ER, estrogen receptor, progesterone receptor, PR, and HER2 can take a few extra days. And if those are different from the biopsy, sometimes we'll do even more studies because we want to see maybe the tumor, the bigger tumor, had several different areas in it, some of which were some grade, some of which were other grade, just for example. I have covered a lot. If you want to learn more about your particular tumor type, visit yerbba.com for your personalized report. Please also like and subscribe because this can help other people. Pretty much everybody with breast cancer gets a pathology report, and it can help people understand what to expect and also a little bit about why it takes so long. That paraffin slicing and the number of specimens that are looked at takes a long time. You actually want your pathology report to take a little while because you want all that information. As always, drop us a comment or a question in the chat. We'll get back to you as soon as we can. And thanks for watching.